Welcome to the Explainer. Okay, picture this. You're in the hot seat, the surgical board exam. The pressure is definitely on. Today, we're going to walk through a classic viva case, gastric cancer, and I'll show you step by step what those examiners are really looking for. Okay, let's dive right in. The clock has started, the examiners are staring you down. What they're looking for is a really clear, logical plan. This first question, this is your big chance to prove you can think like a consultant. So here's our game plan for tackling this case. We'll start with a clinical challenge, then gather clues, confirm the diagnosis, make a plan with the team, and finally cover the surgery and follow-up. All right, first things first, let's gather some clues. You know, a solid history and a good physical exam, that's your foundation. This is where you can rack up some easy points and really start to build a strong case for yourself. This image here gives us a fantastic framework for analyzing pain. I mean, think of it like a diagnostic tool. So let's apply this to our patient. We're going to break down his symptoms, the onset, how long it's been going on, how bad it is, and what makes it better or worse. Okay, so the very first thing you, as the candidate, should be doing is nailing down the details of this pain. We hear it's a dull ache and it's getting worse. But what's really interesting is that nothing specific seems to trigger it. That right there is a clue. It starts to point away from something simple like an ulcer and makes you think about something a bit more serious. And next, you've absolutely got to hunt for the red flags. And wow, this patient has them all. Serious weight loss, no appetite, and melena. Those are the black, tarry stools. These are just classic textbook signs of a potential malignancy and some kind of bleeding in the gut. Now, what about the risks? Well, he's a smoker and he eats a lot of smoked meat. Both are known risk factors for gastric cancer. But the family history, that's a huge piece of the puzzle. His mother had breast cancer young. That should immediately make you think about a possible genetic link, right? Maybe a BRCA mutation or Lynch syndrome. If you mention this in the exam, it shows you're not just focused on the stomach. You're thinking about the bigger picture, things like genetic counseling and screening for the rest of the family. That's a high-level answer. The physical exam. This is where things really start to come into focus. You can see the patient is underweight, pale, what we call cachectic. It all fits with cancer and chronic blood loss. But the absolute key finding, that palpable 4x4 centimeter mass in the upper abdomen. I mean, that really starts to narrow down the possibilities. Okay, so at this point, we've got a really strong suspicion of gastric cancer, just based on the history and physical. So the next logical question is, how do we confirm it? And, just as important, how do we figure out how far it's spread? And you can bet an examiner is going to ask you exactly that. This is a classic question. They're testing you. They want to see a logical, step-by-step plan for your workup. Something that's not just clinically sound, but also, cost-effective. So let's look at the blood work. These lab results, they really paint a picture, don't they? That low hemoglobin, it screams severe anemia, probably from a slow, chronic bleed from a tumor. And the low albumin, that tells us he's seriously malnourished, that cachexia we were talking about. See, these numbers are already telling a powerful story about what's going on with this patient, even before we get a single scan. Now, this is the kind of systematic approach that examiners absolutely love to see. You start with an endoscopy to actually see the tumor. Then you take a biopsy to get that tissue diagnosis. Next up, a full CT scan to look for any distant spread. And to top it off, a staging laparoscopy to check for any tiny bits of disease in the abdomen that the CT might miss. It's just a perfect logical flow. So, the endoscopy finds a large ulcerated mass. Exactly what we were expecting. But here's the next level. Adding an endoscopic ultrasound, an EUS. This gives us so much more detail. It lets us see exactly how deep that tumor has gone into the stomach wall. And that's absolutely crucial for the local staging, what we call the T stage, and for figuring out what to do next. And the biopsy comes back. It confirms what we thought, adenocarcinoma, the most common type of stomach cancer. But look, here's the really critical detail. It's HER2 positive. Now, this is a total game changer. Why? Because it means we can use targeted therapies, like trastuzumab, which can just dramatically improve the patient's outcome. So when we put all the staging information together, what's the big takeaway? Well, it looks like the cancer is just in the stomach and the lymph nodes right next to it. We're not seeing any signs of it spreading to the liver or the lungs or anywhere else. And that right there is fantastic news, because it means we have a real shot at a cure. Okay, so we've got our diagnosis, we know the stage of the cancer. Now it's time to build a treatment plan. And I gotta tell you, in modern cancer care, this is never ever a solo decision. It's all about the team. And this quote, it really nails what it means to be a consultant these days. It is not just about how good you are with a scalpel. It's about leading that team discussion. You're talking with medical oncologists about chemo, radiation oncologists, the pathologists who read the slides, the radiologists who read the scans, all of you coming together to create the absolute best plan for this one patient. So for a cancer at this particular stage, the best strategy is to attack it from all sides. We're going to start with chemotherapy before the surgery. We call that neoadjuvant therapy. The whole point is to shrink the tumor down and zap any sneaky cancer cells that might have already escaped. Then comes the surgery. And after that, we'll probably hit it with even more therapy just to finish the job. All right, let's fast forward a bit. Let's say our patient has finished chemo, and it worked, the tumor has shrunk. Now it's go time. Time for surgery. So let's head into the OR. And here we go, another classic exam question. The examiners, they're not just looking for you to name the operation. Nope, they want to know you understand the why, the cancer principles behind it. So you've got to be precise here. So for this specific tumor, there are 3 non-negotiable steps. First, a total gastrectomy. The entire stomach has to come out. Second, a D2 lymphadenectomy. Now, this isn't just taking out a few lymph nodes. This is a super meticulous dissection to clear out specific groups of nodes around the stomach's big blood vessels. It's way more extensive than a D1 dissection, and it's really the standard of care if you're going for a cure. And third, you've got to send the margins for a frozen section right there in the OR. You need that confirmation that you got a clear edge, an R0 resection, which means 0 microscopic cancer cells left behind. And take a look at this timeline. It really shows that the surgeon's job is far from over when the operation ends. See how the follow-up is really intense for the first couple of years? That's because the risk of the cancer coming back is highest then. After that, as the risk drops, we can start to space out the visits. But surveillance isn't just about scanning for cancer, right? It's also about regular checkups, and critically, it's about managing the long-term consequences of the surgery. I mean, think about it. After a total gastrectomy, nutrition is a massive, lifelong challenge. And that pretty much wraps up the case. But wait, a really sharp examiner isn't going to let you off the hook that easy. They'll always push you one step further. This final question forces you to think beyond just cutting out the cancer. It makes you consider the patient's quality of life for the long haul. Are you thinking about iron, B12, calcium, and vitamin D deficiencies, and how you're going to manage that stuff for the rest of their life? That's what separates a good surgeon from a truly great one.